I will be doing my current events report on the new census data showing the child uninsured rate rose to 6%, the highest in about a decade. I'll briefly summarize the news, explain why this is a social problem, connect to the UDHR and NASW Code of Ethics, flag relevant policies, and end with discussion questions focused on practical safeguards. On September 9th, 2025, the Census Bureau released 2024 data indicating the child uninsured rate increased from 6% from 5.4% the year before. Follow-up coverage in mid-October 2025 highlighted that this is the highest rate in roughly a decade and pointed to declines in Medicaid/CHIP as a key driver. A couple of clarifiers for our class. This is based on large nationally representative surveys. It's not a one-county blip. The trend is uneven across states. Where public coverage is harder to retain, children are more likely to become uninsured. Analysts warn that without retention safeguards, the rate could creep higher, especially in households facing language barriers, unstable work hours, or limited internet access. So the headline is simple: 6% of kids uninsured, but the mechanisms are administrative, renewals, verification, and documentation. Why this is a social problem? This matters because insurance status for children is directly tied to preventative care and continuity of treatment. When coverage lapses, kids miss well child visits, immunizations, dental care, and timely management of asthma or other chronic conditions. Families experience financial stress and may defer needed care, which can widen health inequities. What we've seen since the pandemic protections ended is a lot of churn, eligible people losing coverage for procedural reasons, not because they no longer qualify. From a systems view, this isn't just about individual choices. It's about whether our administrative processes are designed to keep eligible children enrolled. Through a human rights lens, UDHR Article 25 affirms the right to an adequate standard of living, including Medicare, and Article 2 prohibits discrimination. When coverage losses disproportionately fall on low-income families, immigrant households, and communities with language barriers, those principles are implicated. Through a professional ethics lens, the NASW Code of Ethics calls us to service, social justice, dignity, and worth of the person, importance of human relationships, integrity, and competence. Two standards feel especially relevant. 1.01, commitment to clients, promote client well-being even when rules are complex, and 6.04, social and political action, engage in advocacy to reduce barriers and expand access. So our dual role is clear: help families navigate today's rules and advocate for fairer ones tomorrow. Relevant policies shaping the trend. There are three policy levers I want us to watch because they determine whether eligible kids stay covered. 1. State renewal processes. Does states prioritize ex parte renewals? That is, using existing data to auto-renew before asking families for paperwork. Are notices clear, multilingual, and timely? Are documentation demands realistic for families with variable hours or limited broadband? 2. Child-friendly eligibility rules. 12-month continuous eligibility for children is a proven buffer against churn. State income thresholds and CHIP policies vary. Small differences can mean big enrollment gaps. 3. Federal context in fall 2025. Debates over ACA subsidy extensions and analysis around Medicaid work reporting influence parents' coverage and indirectly their children's care continuity. Each lever can either shield families from losing coverage for paperwork reasons or expose them to avoidable lapses. Implications for social work practice. Here's how we translate this into practice. Micro, which is direct practice. Add a quick coverage check to intakes. Have you received any mail from Medicaid or CHIP? Any changes in job hours? Use a one-page checklist. When to report changes, what counts as proof, where to upload documents, how to request good cause exemptions when life happens. If coverage is lost, connect families to FQHCs, school-based clinics, and prescription assistance so kids don't miss care. MESO, which is the programs and community. Co-host renewal events with schools, clinics, and libraries. Offer evening hours and interpreters. Set up text/email reminders aligned with renewal cycles. Keep strips clear and culturally responsive. Track why coverage is lost in your agency data. Flag procedural versus eligibility denials so we know where to intervene. Macro, which is the policy and advocacy. Advocate for ex parte first, 12-month continuous eligibility for kids, accessible language services, and good cause standards that reflect real life. Share local evidence with decision makers. A simple graph of how many families you helped in termination by fixing paperwork can be powerful. Partner with NASW, chapters, and coalitions to push for simplified reporting and child-centered design. Bottom line, our ethical commitments point to practical, evidence-based fixes that reduce churn. Okay, now I want to hear your design ideas. If you could implement one safeguard first to protect eligible kids from losing coverage, which would you choose and why? It could be ex parte renewals, 12-month continuous eligibility, multilingual reminders, time to renewal cycles, or broader good cause exemptions for reporting lapses. Second question, what roles should schools and pediatric clinics play in keeping kids enrolled during 2025-2026? Thanks for engaging with this. I've listed the census release and recent October reporting, plus briefers from health policy groups and CMS snapshots if you want to dig deeper. I also post the discussion questions in the thread for easy access. Thanks for watching. I'm looking forward to your ideas.